Okay, let's talk about one of the highest stakes situations in medicine, a pediatric emergency. I mean, the pressure is just incredible, right? Every single second counts. And when it comes to meds, there is absolutely zero room for error. A tiny miscalculation, it can be devastating. So today, we're going to break down the essential drug doses you have to know, and we'll turn those tricky calculations into clear, simple, and actionable steps.
So you might be asking, what's the big deal? Why is this so tough? I mean, why can't we just have a standard dose for kids? Like we do for adults in a lot of cases.
Well, it all boils down to one simple, crucial fact. Children are not just tiny adults. It's not even close. Their metabolism, their organs, their whole body composition, it's all completely different. And what that means is that pretty much every single emergency med has to be calculated precisely based on their weight. It's a whole different ballgame.
All right, so here's our game plan. We're going to start with cardiac arrest essentials, then jump into seizure and sedation. After that, we'll look at a key reversal agent, and we'll wrap up with some supercritical dosing details that you absolutely cannot afford to miss. Let's get into it.
Okay, first up, the most time-sensitive scenario you can imagine, cardiac arrest. These are the drugs that form the absolute backbone of pediatric resuscitation.
All right, here are the big four. You've got epinephrine, that's your main go-to vasopressor, atropine for bradycardia, when the heart rate is dangerously slow, then there's lidocaine for those scary ventricular arrhythmias, and finally, sodium bicarbonate for very specific situations, like a really prolonged arrest. And check this out. Notice the different ways you can give them: IV, IO, or even down the endotracheal tube. That flexibility is key when getting access is a nightmare.
Now, let's zoom in on epinephrine because this is a huge point, a classic trip-up. The dose itself, the milligrams per kilogram, it's actually the same, but the concentration you use totally changes depending on the route. If you've got IV or IO access, you're using the 1 to 10,000 solution. Simple enough. But what if you don't? What if all you have is the ET tube? Then you have to use the more concentrated 1 to 1,000 version to make sure it gets absorbed properly, and you still have to dilute it. I'm telling you, mixing these two up is such a common and dangerous mistake.
Okay, let's talk about atropine. Think of this one as having a built-in safety guardrail. So, you do the math, right? 0.02 milligrams per kilogram. But here's the rule. No matter how tiny that baby is, you can never give less than 0.1 milligrams. Why? Because if you go too low, you can actually get the exact opposite of what you want, a paradoxical slowing of the heart rate. So, 0.1 is your absolute floor. And speaking of our tiniest patients, here's another one you have to remember. It's for sodium bicarbonate. The standard dose is 1 milliequivalent per kilo. But for neonates and really small infants, you got to cut that in half. Use 0.5 instead. This is so important to avoid some really dangerous fluid and electrolyte problems.
All right, let's switch gears to another super common and scary pediatric emergency, seizures. The goal here is simple: stop the seizure, fast.
And for that, midazolam is often your go-to drug. The beauty here is how simple the decision-making is. It all comes down to one question: do I have an IV or IO line? If you do, great, you give a smaller dose as a slow push. If you don't, no problem. You just use a larger dose and give it IM or IN, intramuscularly or intranasally, to make sure it gets in and works fast.
Okay, on to our reversal agent. We're talking about naloxone. This is the life-saving antidote for an opioid overdose, which, sadly, is something we do see in kids.
Now, what's really important with naloxone is that it is not one-size-fits-all. There is a super clear dividing line you have to know. For the little ones, kids under 5 or who weigh less than 20 kilos, you're doing a weight-based dose, 0.1 milligrams per kilogram. But for any kid older or heavier than that, forget the calculation, you just give a flat dose of 2 milligrams. It's that simple.
All right, let's bring it all together and really hammer home some of those little details, those nuances we've talked about. Because when things get crazy, these are the points that can really make or break a situation.
So think of this as your quick-hit mental checklist. Atropine. Remember, it has a floor and a ceiling, a minimum dose and a maximum single dose. Lidocaine. It's not just the bolus. You often follow it with an infusion. Magnesium sulfate, you give this one slow, over 10 to 20 minutes. Never, ever slam it in. And calcium chloride, always double-check that your math is based on that 10% solution. Got it?
So when you step back and look at it, you realize it's not just one kind of calculation we're dealing with, right? I mean, yeah, the huge majority of what we do is weight-based, that classic milligrams per kilogram. But then you've got these other categories, like the flat dose we saw with naloxone for bigger kids. And you've got the really complex ones, the continuous infusions, calculated in micrograms per kilogram times per minute. And then you have these rule-based doses, like atropine, with its own minimums and maximums. It's a lot to keep straight.
And that really brings us to the final big question. All of these calculations are absolutely critical, obviously, but let's be real, they're not all equally difficult to perform under pressure. So I want you to think about this. In the middle of a crisis, when your heart is pounding and a kid's life is on the line, which one of these dose types do you think is the easiest to mess up? Is it the straightforward weight-based one, the one with the special rules? Or is it that complex infusion calculation? Which one really needs that extra set of eyes, that careful double check? It's something we should all think about.